It's her first time on Healthcare Unfiltered and won't be her last time. That's what Dr. Cami Maddocks promised me. Cami, welcome to the show.
Thanks, Chadi. Nice to be here.
So, as you see here, Healthcare Unfiltered right here. And a quick intro as to where you are, where you practice. And I'm always curious what gets someone interested in the field that they spend their career at. What got you into lymphoma as you make your introduction?
I am at the Ohio State University James Cancer Hospital. I practice lymphoma here. I do lymphoma. I see patients in clinic with lymphoma and then do lymphoma clinical research. And then I have some different leadership roles within our division and in the James Cancer Center. I do lead our lymphoma program and have done that since 2017. I primarily see, my interest is really in aggressive lymphomas, mantle cell lymphoma, large cell lymphoma, but I see all B-cell lymphomas, all B-cell non-Hodgkin's lymphomas and Hodgkin's. I actually became interested in lymphoma when I was, or heme in general, when I was a resident. I did my residency at Mayo Clinic and worked a lot with Tate Shanafelt. At the time, had done and just really I enjoyed him. I enjoyed his energy and working on the research project. I work with him. And then I really like my inpatient lymphoma rotations. I just like the patient population. You know, you see all ages, you see patients who are cured of their disease, but you also see some challenging cases. And that connection is what brought me to Ohio State for fellowship, and that's where I stayed.
Yeah, Tate is a great guy. He since moved to Stanford
Yeah.
as Chief Wellness Officer. Yeah, I need to bring him on the show to understand what does that actually mean. That's a good topic. So, Cami, I know this sounds like a humongous task, but I do think we can do it because I think I've done a lot of shows into a particular disease like Hodgkin, mantle cell, things like that, DLBCL. And I'd like to kind of look at the past 1 to 2 years and maybe capture the essence of what really excited you as a lymphoma specialist and researcher, what struck you, and maybe the road ahead, what you are looking forward to over the next couple of years. And we can pick and choose which ones we talk about because there's a lot of things happening. And I think it's a nice exercise to contextualize certain things. Well, we'll start with what we do a lot of, which is aggressive lymphomas, aggressive B-cell lymphomas. In aggressive B-cell lymphomas, pick or choose DLBCL or Burkitt's. What has sparked your interest over the past 1 to 2 years, and what are you looking forward to in the next 1 to 2 years?
So honestly, like I think that there's a theme across probably a lot of the lymphomas that I would say, you know, has sparked interest over the last few years, probably really like the last 5 years, and then became different over the last couple of years, and then moving into the future. But it's really kind of the role, I would say, of the immunotherapies or in the treatment of lymphoma, right? So starting with some of the chimeric antigen receptor T cell products being approved and moving, you know, from third or later line to second line in aggressive lymphoma, large cell lymphoma. And now we have trials looking at in high-risk patients, you know, even giving CAR T cells in the frontline setting with minimal chemoimmunotherapy and then CAR T cell. But then that's been followed by the bispecific antibodies. So immunotherapies in you know, a little bit different way, but just the efficacy looking at that in relapsed large cell lymphoma. And I think now the future, what we're seeing is randomized trials, right, incorporating those agents into frontline therapy with standard chemoimmunotherapy and just in general moving them earlier into lines of therapy. And I think if you look at that, I mean, that's been very exciting in large cell lymphoma, but I think it's also been exciting. I mean, we've seen that in follicular, the role of CAR T and now bispecifics in the relapse refractory setting. And then we have studies ongoing, moving them into second and even first line therapy. And in mantle cell as well, which, is a particular area of interest. We have not yet seen approval of bispecific, but now we have 2 CAR T cell products approved, moving them earlier into lines of therapy in patients with high-risk disease. And then hopefully we'll be looking at bispecific approval in that relapse refractory setting in mantle cell as well.
Cami, and let me just dissect this a little bit, because like for diffuse large B-cell lymphoma, there's a couple of things that I've always contemplated and thought about. It seems to me that I'm curious your thoughts about the cell of origin. 20 some years back, everybody in the lymphoma community was so excited about the ability of telling a DLBCL patient whether they have worse or better prognosis. This has not necessarily translated into selecting therapy based on that. So my first question is, are you seeing a change in that, where we are selecting treatment in the front line based on the cell of origin? That's one question. And the second question, which is kind of similar to it, now that you've got the, Polivy plus R-CHP, you have the R-CHOP, and you have the EPOCH-R, and you have maybe 3 regimens frontline. Are we doing a better job in deciding who should we give R-CHOP to versus adding the polatuzumab versus so these are the 2 questions I have in that particular disease.
I think the challenge with cell of origin there's been several challenges, but we now know with further molecular studies that even within cell of origin, there's bad actors and good actors within both GCB and ABC or non-GC. And so we're just not able to identify those in a clinical setting early on to be able to help prescribe therapy, right? I think, is it no longer relevant? There's still some relevance, and even you mentioned the Polarix trial and polatuzumab in frontline. That trial took all comers. It was not designed to detect a difference in cell of origin. But if you look at the subgroup analysis, it did show improvement, appeared to be more in the non-GC subtype. And there are, there's, I would say, probably mixed across the US. There are people who feel like, based on the approval, stage 2 to 4 disease, use it in everyone. And then there are people based on subgroup analysis and analysis of other trials incorporating POLA in the relapse refractory setting. That really it is the non-GC patients that benefit from that, and that's who they're prioritizing that therapy for. So I think to some extent, even with that trial, it wasn't designed like the Phoenix trial where they looked at ibrutinib in, non-GC or some of the other trials. But still, people are using cell of origin, I think, in practice to determine who they're using that treatment for versus just standard R-CHOP.
So you're like today, this is in 2024, the Polivy plus chemotherapy is reserved for the non-GCB.
I would not say standard, but I would say based on that data, there are people that only would use it in non-GC. If a patient has, advanced stage disease, stage 4 disease with high-risk IPI and is GC subtype, I'll still use it. So I'm not solely basing that decision on the non-GC. But I do think if you look at that subgroup analysis, there is a suggestion, and I do think that there are people that are solely using it in that population of patients.
Makes sense. So, maybe this is the beginning of treating after 20 some years. Because we had so many of these failing studies, I think that's I can appreciate that in terms of deciding the therapy based on the prognostic relevance of this. Yeah.
And as far as R-CHOP, I think we know that people with limited stage disease, most of them, right, do very well. Limited stage disease, low risk factors, do very well with standard R-CHOP therapy. As far as who doesn't do well? Well, we know that certain patients, like patients with translocations of c-Myc and BCL2, do very poorly with standard R-CHOP therapy. The Polarix trial did show benefit in patients with polatuzumab. I think even there, you saw that the IPI 3 to 5 seemed to benefit more as well than patients with lower risk disease.
Yeah. And then double hit, triple hit, you were starting to allude to it. These are the ones that today you're not using R-CHOP for. You're using something else?
Correct. So I still use, dose adjusted R-EPOCH for those patients. That's obviously based on, a phase 2 single arm phase 2 study and then retrospective data. The randomized trials, even if you look at the old CLGB trial with R-CHOP, R-EPOCH, the Polarix trial, I mean, a lot of those trials that had patients were eligible, but there was such a small number enrolled that I think you can't really say much about, whether not having a difference in those patients is significant.
Right.
But yes, I do still treat that patient population with the EPOCH regimen.
And then in DLBCL, and then we'll move to other lymphomas. The other question I had in mind, I always think, I mean, it seems that the field has come to a consensus into when do you offer transplant versus CAR T in relapse disease, in first relapse. It seems like it, if it's like later relapse, maybe you do transplant, earlier relapse, maybe you do CAR T. I mean, but that's really, is it a consensus or do you think it's data driven?
I mean, I think it's probably, so it's a consensus, but it is data driven, but it's because the data isn't there otherwise, right? Like the trials in CAR T cell all included only those patients with high risk disease defined by being refractory or relapsed within a year of therapy. So it's not like we've actually taken those patients who have later relapses where we still think of the standard, if they are able to tolerate it, as further intensive chemo and autologous stem cell transplant consolidation. But we haven't actually done the trial in that population of patients in late relapse to look at transplant versus cellular therapy.
Yeah. And then along these lines, there are several CAR T constructs right now that are kind of approved, I guess, for relapse disease. If I bring 10 lymphoma colleagues, do you think we have a consensus which one to use when you decide to use one?
No.
What kind of question is that? We'll get 11 opinions.
Yeah. I think you probably would. I mean, if you look at, right, when you look at the trials in second line, 2 were positive and 1 was not. So I think like it's clear that that's, not the product that you're using in that setting. And maybe even that, is going to drive more people's decisions in third or later line settings, specific to large cell only. I think if you look at the different products and the data in the different diseases, there, you might interpret what product is better to use for a specific disease for different reasons. I think probably when you look at toxicity, take into account efficacy and toxicity, you might have a consensus on maybe, 2 of the 3 products being used as far as, and then kind of deciding based on patient characteristics, comorbidities, age, which is the preferred product between the 2 in those selected patients.
Okay, so you alluded a little bit about the other portion of the aggressive ones. We'll get to mantle cell, but there's one part of the aggressive ones that I really feel they don't get talked about enough, maybe because of the frequency. And one is Burkitt and one is Richter. So when we think of Burkitt, I mean, are we happy with the current state? Like, do you feel there's room to improve? That's a silly question. There's always room to improve. But, like, what are we doing with Burkitt and what are we doing with Richter nowadays, 2024?
Yeah, I mean, I think that there's always room to improve. Certainly Burkitt's is very curable compared to some things, but there's still, for patients who are not, there are patients who are not cured. So like you said, you can always make improvements there. I think the challenge in Burkitt's is really the patients that don't respond to initial therapy. And there just is not really a lot of great options for patients with refractory Burkitt's or relapse, but most Burkitt's are refractory if they don't respond, right? If they get a remission, most of them do well. I think, there was a kite study that was looking at the Axicell product in patients with different kind of rare subtypes. But I think I don't know if I think I want to say that they closed that early without fully accruing to the Burkitt's population, or they only accrued a small number and then didn't expand it. I mean, I think that's an area that it would benefit from, this type of, looking at therapies like the CAR T and bispecifics and outcomes in that. I think, I'll be honest, I've not treated personally a refractory Burkitt's with CAR T. I think in talking to some other people, it seems like there are patients that respond to it, but don't necessarily have durable responses to it. So there still has to be like a plan for, then do you get the CAR to get a response and consolidate with allotransplant? So I'm not sure that the products we have are the answer for Burkitt either.
Yeah,
Richter, I would probably say the same thing for. I mean, there's a lot of work going into that, right? Looking at adding therapies, some of the different targeted therapies to chemoimmunotherapy in the front line, looking at CAR T cell for that patient population. Still, from what I'm seeing, the outcomes are not as good as they are in
I
other
feel
situations.
Richter and relapsed, or like you said, it's great Burkitt's. You get 70-80% response rate. It's wonderful. That's really what you do with these 20% that don't respond. It's really, when I treat patients, it's gratifying to see the response, but it's a disaster when you don't get a response, really.
Right. And it's a further challenge because not only are there not a lot of trials, but then there's only like, a handful across the US, and it's hard to get a patient to the trial and get them worked up and on trial, right? Because it's a lot of times it's bad and, rapidly progressing disease.
Sure. Let's talk about mantle cell. I know you do a lot of this. You're very passionate about it, and like other lymphomas, but mantle cell, has changed a lot. Whether it's frontline, relapse disease, there was, so much about transplant, not transplant. How are we approaching mantle cell today in 2024?
Yeah, I mean, back to your comment about if we put 10 people in a room, what would happen? We would get like 27 opinions on this one. I think I mean, I've heard comments such as when in meetings like frontline treatment for mantle cell is like a mess, I don't think it's a mess. I think there are lots of options. I just don't think there's a right option at this time. I still think, we've seen data that maybe we don't need to transplant patients. I would say that I've taken that approach. I mean, looking at using BTK maintenance, the Triangle trial showed us that people did better with BTK therapy and maintenance in the frontline setting, but we still don't have the answer when you look at it, did the auto or no auto. So ibrutinib added in that study to chemoimmunotherapy and chemoimmunotherapy plus auto, but there wasn't long enough follow-up in the two BTK containing arms.
Does it matter what you give though, in terms of, is it like BR or R-CHOP? Does it matter what you give in addition to ibrutinib?
So I don't think we know that. I mean, the SHINE study, I think that probably, first of all, let's step back. I think the importance is probably most likely coming from the maintenance portion, not necessarily the, what you're adding to the induction, right? We've seen that the one thing in mantle cell lymphoma that improves overall survival is rituximab maintenance. And likely, if you look at, the SHINE trial, the recently reported ECHO triangle, the triangle study, what people are benefiting from, I think, probably is the maintenance portion of the
Mhm.
use of the BTK inhibitor. Does it matter what we give for frontline treatment? I mean, we've seen SHINE and ECHO, right? So those have both been reported out, both prolonged the progression-free survival, but there was more toxicity associated, particularly in the SHINE trial. So I think, you've seen that it improves outcomes with BR. You've seen the RCHOP, RDHAP regimen. So I think probably it doesn't necessarily matter. It's probably the idea of giving the BTK maintenance with the rituximab
It
maintenance.
doesn't matter what chemo I would give, because there was a time where there was a big push that you have to give like cytarabine as part of the induction therapy. And is this out of favor now, or it's not critical? The Nordic trial that was very highly publicized.
I mean, I think when you look at that, right, they showed that people benefited from cytarabine containing inductions prior to autologous stem cell transplant. So the question is, do you need the cytarabine if you're
Right.
not going to transplant them? The ECOG study, right? So there was a randomized ECOG study that looked at BR high DAC, BR Acala, BR high DAC Acala. That has completed enrollment. We have not seen the results from that yet. So I think that might, help answer some important questions as far as efficacy and toxicity.
There's with mantle cell also, it's one of those diseases where I always was it actually was always intimidating disease to me, because there was a lot of research on the prognostic parameters, aside from the histologic appearance, but there's on the molecular level identifying certain biomarkers that convey poor prognosis. Have you been able to apply some of these into your decision making in terms of transplant, no transplant, based on the the prognostic significance of what you find in a particular patient versus another?
I think the biggest thing from that is when you look at patients who have TP53 mutations, like those patients don't benefit from transplant. And I feel like, honestly, I think those patients shouldn't be treated with chemotherapy at this point. But those are definitely not patients that I transplant, because I think it adds a lot of toxicity, and there's clearly not a benefit to more intensive chemoimmunotherapy in those patients.
So you recommend maybe clinical trials for these patients?
I try very hard,
Yeah.
to get them on a clinical trial, or consider, I think we've had this conversation before, but we don't have a BTK inhibitor approved in the front line. Even since the last time we talked, we still don't have that, hopefully in the future.
Wait,
But I do think, it's
I thought
trying to prescribe that
you're
off
not
track.
using ibrutinib in the frontline.
It's in the guidelines list, but we don't
It's not
have
FDA
approved.
approved. I see, I
It's
see, I
not
see.
FDA, like we have no FDA approval for any BTK inhibitor.
Interesting.
So I think it can be a challenge in those patients if you want
Right.
to get them started on treatment and you're trying to fight with an insurance company, to approve one of those
Yeah.
therapies, which, you can do, but
No, that's a very
I
good, it's an important point.
yeah. And hopefully that'll change in the future, but I
And then you've
think,
got several. You've got several that could be approved. I mean, you got the Acala versus ibrutinib, but to your earlier point, the SHINE study used ibrutinib, did not use Acala.
right, and so that was withdrawn from the market, and so that's
Right.
not approved in any situation. And really, the triangle study too used ibrutinib, right? So
Yeah.
you're kind of even in that situation extrapolating that data, which I think you can do with the second generation BTK inhibitors,
Okay,
but
now I can understand why we get 27 opinions, Cami. with this.
Well, but I mean, you asked like the important, like is cytarabine important? I guess that, one of the things that I think about in mantle cell lymphoma is chemotherapy important. Like, really, should
Yeah.
the majority of these patients be treated with non-chemo approaches like they've taken in CLL? And don't get me wrong, there are some patients that get very durable remissions to chemotherapy, be it, more intensive chemotherapy or even BR can have really good results. But I do think that question is out there, is there a large population of these patients who we could be treating with non-chemo
Yeah,
approaches?
yeah. You know, yeah, it's actually interesting in deciding which chemotherapy to give used to be one of my most challenging decisions in mantle cell. I mean, at the time when I was seeing patients, I was just recommending transplant and per CR for everybody, but this, it was not always easy. And then you've got CAR T that was also approved. Have you been using CAR T in mantle cell?
Yes. I have been using CAR T cell and mantle cell, and I think it was very exciting to see that the second product was just approved, um, very recently at the end of
Yeah.
May in mantle cell lymphoma. Because I do think one of the challenges with CAR T, I mean, mantle cell lymphoma is a population of older patients. I mean, we see young patients, certainly, but I mean, the majority of patients are older and in the setting where they've already had 2 prior therapies. I do think, there is more toxicity associated with Brexucell and with CAR T and mantle cell than what we see in the other lymphomas. So have been using it, but I do think it was nice to see the approval of the second product, which, obviously they haven't been compared to each other. But if you look at the data, the CRS and neurotoxicity are lower high grade and all grade. And I think that will expand the potential for CAR T cell therapy in this population of patients, because I think it opens it up to some of those older patients who you really worry about tolerating.
Right,
Um,
right. So let's just do a little bit, and I think we still have a little bit of time about low grade. Like, what's in the world of follicular lymphoma? What has intrigued you over the past year or so, and what are you looking forward? Just like general themes for follicular lymphoma. I mean, and I know we have the high risk ones, the ones that progress early, and the lower risk, and also frontline therapy could be challenging.
Yeah, I mean, what I think is what we see nice in follicular lymphoma is the efficacy of bispecifics there. And I think that the idea of moving those into the frontline setting for a disease like follicular lymphoma is very exciting.
So, what are you doing now? I mean, we've been trained to think of patients who progress within 24 months after initiating therapy carry poor risk, and this has been validated in several settings. So, what are we doing for these patients?
So my approach to those patients now, of course, it depends on what they have for frontline therapy. I mean, when you look at bispecific and CAR T, those are both approved in 3rd or later line settings. So for a lot of the patients that have early relapse or kind of that POD24, number one, making sure they don't have transformed disease, because there have been studies showing that a high proportion of those actually have transformed disease. And then, you're going to approach that as treating them for transformation. I think my approach largely has been in these patients to think about lenalidomide-based therapy. And then if they progress, after that, then thinking about bispecific or CAR T cell therapy. I think if you had those options in the second line, that might also be a nice consideration.
And these are off studies, like you're able to do CAR T or bispecifics in the routine clinical care?
In 3rd line setting.
3rd line.
Yeah.
Okay. Transplant for follicular lymphoma, is it completely falling out of favor nowadays, or you still have a area?
I think that auto transplant outside of transformed disease, And even there, you have to look at the role that CAR can play. But I think that no, I haven't been recommending it. We used to, the POD24, you used to recommend more autologous stem cell transplant in those patients after their therapy for second line therapy. But with the availability of the CAR T and, like I said, now the bispecifics, no. And I would say that the role, of allogeneic transplant, not that it was huge, but even that role in the era of these current therapies is probably lower than it was.
Yeah. And is there, I mean, in DLBCL, we can tell based on the cell of origin prognosis in the beginning. For follicular lymphoma newly diagnosed patient, are you doing anything on the molecular level to kind of differentiate good versus low prognosis, or it's really not as mature as DLBCL?
There's nothing done in routine clinical care,
Right.
outside of Flippy.
Yeah. Okay. So then what else in terms of lymphoma? I mean, I think we talked about these two bigger ones. Anything in Waldenstrom's or CLL that is exciting you? I forgot to ask you if you're seeing CLL, because I know sometimes in certain institutions, leukemia folks seeing the CLL versus the lymphoma folks, but I don't know how it is at Ohio State.
Yeah, so we're separate. We have a lymphoma group and a CLL group. So the CLL group sees our CLL and our Richters.
Okay. So in Waldenstrom's, anything that is intriguing, or you're doing anything differently for these patients?
BTK has been effective there. There's ongoing look at kind of the new BCL2 inhibitors in combination, either single agent or combination with BTK in that disease. I don't think, the potential for bispecific antibody in that is there. We just don't have the data.
Yeah.
But that's probably going to be looked at in the future, marginal zone lymphoma.
Yeah. So my last question, Cami, is just in general, what studies out there today that are ongoing and accruing that we're looking forward to, that you think are really pivotal, or if there's any? Like, I recall, years back, I was so much looking forward to the intergroup study with R-CHOP versus EPOCH-R. That was like, where are we going to get the results? And we got the results. Is there anything of that magnitude today happening in any kind of lymphomas where the lymphoma folks are looking forward, well, this is going to read out maybe in the next 1 to 2 years, and we're very much looking forward to it? Or there's not a whole lot happening right now in terms of these major big studies?
I think if you look at mantle cell, there are studies ongoing that are looking at chemo versus, rituximab BTK inhibitor therapy. And I do think that that's a question that we probably needed to ask for a long time, and haven't done it. We have a lot of single arm phase 1 trials looking at those non-chemo approaches in the frontline setting. But I think that randomized data, both from the US and UK ongoing trials, I think that's exciting. There's an alliance trial in elderly patients looking at our Zanu for 6 cycles, and then they randomize patients who achieve a CR to continuous therapy versus therapy again at relapse or progression, so that'll help us kind of tease out BTK for patients who respond to BTK in the frontline, what's the role of retreatment. I think that in large cell lymphoma, the ongoing trials looking at adding the bispecific antibodies to frontline chemotherapy, that potentially, if you look at, what has the potential to further the standard of care in the frontline treatment of large cell lymphoma, that, and then I think in follicular lymphoma, looking at the bispecific antibodies up front, including, there's trials looking at bispecific antibody versus rituximab, but there's also bispecific antibody with rituximab len, And I
Yeah.
think that's intriguing in that disease.
It's hard to say that I'll be seeing you at ASH. I mean, it's like if I think of ASH, I'll be thinking of like winter and December, and I'll be thinking like the time flew by. But you know, it just seems like it's probably around the corner. It's crazy,
I know it is crazy how time flies.
really. I mean, hey, this was so good. I really enjoyed just kind of like picking your brains on into what's going on. I still think there are certain questions that we should really put a lot of resources into, and try to really resolve some of these, because you know, like just, you know, the rapidly progressing follicular lymphoma. When you have a follicular lymphoma that's responding, doing well, going on for 10 years, it's easy. But you get one of those and makes you just, you know, think what to do. And we've all had these patients where you just do everything and nothing is just, and not transforming. We're not talking transforming, just
Right,
that.
just like high risk, all of the diseases have patients with very high risk disease that sometimes you can explain, and honestly, sometimes you can't really explain it.
Yeah, yeah. Well, I really appreciate you spending some time with me. I'll see you in San Diego in a few months, and then we'll probably do another edition of this. I can't believe it, the beginning of 2025. We kind of do a little bit of recap of what we saw at ASH. You know, you're going to be a frequent guest on Healthcare Unfiltered.
I love it.
Thank you so much, Cami. Dr.
All
Cami
right, thanks for
Maddocks,
having
Ohio
me.
State, you know, the Ohio State
The
University.
Ohio State.
Please forgive me if I just said Ohio State. Thank you so much for coming on.
Yeah, thanks, Johnny.